Epidemiological research methods. Other study designs. In a previous presentation, we looked in detail at a widely used epidemiological research method in eye care, the cross-sectional study. In this presentation, we examine 4 more useful research study methods in eye care. By the end of this presentation, you should be able to describe the characteristics of the case control, cohort, and randomized controlled trial study designs, identify their strengths and weaknesses, appreciate the characteristics of qualitative study design. Case control studies are used to identify risk factors for a disease. How they are conducted is that a group of people with the disease, let's say cataract, are taken. They are known as cases, and they are compared to a group of people without cataract, who are known as controls. Then the exposure to certain risk factors or other characteristics are measured in the cases and the controls. For example, these exposures might be smoking, age, or gender. In case control studies, we measure exposure to different factors in both cases and controls. We then calculate how the disease is associated with the exposures, for example alcohol consumption, to see if the cases have been more exposed to risk factors than the controls. This calculation is called the odds ratio. Case control studies have a number of strengths. They are quicker and cheaper than other study designs, especially if hospital cases and hospital controls are used. They are useful for examining rare diseases, as the cases, who are the people with the disease we're examining, can be identified using a hospital or disease register. More than one exposure can be looked at. We can examine both cases and controls for as many exposures and characteristics as we want. Case control studies also have some weaknesses. They are prone to bias, especially selection and recall bias. Selection bias happens when the cases and controls are selected differently, using different inclusion criteria, or basing selection on the exposure status. Recall bias is when people with the disease remember events differently from those without the disease. This can happen because people with a disease may search their memories more thoroughly than unaffected controls when asked if they have been exposed to specific risk factors. Other weaknesses of case control studies are: temporality between exposure and disease can be difficult to ascertain. For example, a person's diet may have changed due to the disease and not that the disease resulted from a diet change. They are not good for studying rare exposures unless the exposure is common among those people with the disease. There can be problems with generalizing from the study results, especially if using hospital controls. It is a well-known fact that hospital patients have a less healthy lifestyle, for example they smoke more, than the general population. We cannot measure disease incidence using case control studies. A cohort study is what's called a longitudinal study, and it starts off with a group of people with a certain characteristic that are disease-free at the beginning of the study period. They are then followed up for the specified study period, and at the end of the period we see who has developed the disease. And from this you can calculate the incidence of the disease and the risk of disease. What is important about cohort studies is that the follow-up is complete as possible, because if too many people drop out, you end up having incomplete information. Cohort studies can be retrospective, which means that both the exposure and the outcome have already taken place when the study is carried out. For example, incidence of retinopathy of prematurity based on a database or register of low birth weight babies. A retrospective or historical cohort is much quicker and cheaper to carry out than a prospective cohort study. Strengths of a cohort study. As exposure comes before outcome, cohort studies can give some indication of temporality. There is less risk of bias. They can be used to study multiple effects, that is, more than one outcome, of one exposure. They are good for the study of rare exposures, especially in occupational settings. Incidence can be measured directly, as we know how long a person has been at risk before development of the disease. Causality can be inferred. Weaknesses of cohort studies. They are generally expensive and can take a long time, depending on the exposure and disease outcome being studied. They are not good for studying rare outcomes, as this requires a very large sample size. Loss to follow-up can be a problem, especially if this is related to the exposure or outcome. Misclassification of exposure or outcome can be a problem. A randomized controlled trial is an intervention study. The key word is randomized. The two groups are randomized to whether they receive the intervention or whether they do not. And the intervention can be different things. It can be either a treatment, a vaccination, or a screening method. The randomized controlled trial is known as the gold standard of study designs for testing and intervention. How do we decide which people get the intervention? This is done by a process called randomization. Random assignment means that each individual has the same chance of receiving the intervention or not. This probability is independent of what the person before has received. If properly done, randomization eliminates selection bias. The only difference between the groups should be the intervention. Strengths of RCTs. A well-designed randomized controlled trial provides the strongest evidence of any epidemiological study design that a given intervention is effective. The aim of randomization is to ensure that any observed differences between the treatment groups are due only to differences in the treatment or intervention. With good randomization, all participants have the same chance of allocation to the treatment or control group, regardless of when the participant enters the study. Weaknesses of RCTs. Subjects in an RCT may be more willing to comply with the treatment regimen and so may not be representative. RCTs are expensive. Qualitative research is very different from the methods we have already discussed and is most often used by sociologists. It does not use statistical methods, but focuses instead on understanding people's perspectives, behaviour and motivations. In qualitative research, sample size is difficult to predict in advance, as fieldwork usually continues until there is deemed to be enough information. This is called the saturation point. For example, we might use a qualitative study to assess why cataract blind patients in a community do not come for surgery. Information could be sought from the cataract blind, relatives, community leaders, and health workers. This would give an in-depth understanding of social and behavioural influences on barriers to uptake of cataract surgery. Qualitative methods include focus groups, in-depth interviews, semi-structured interviews, observation. The use of some quantitative data along with qualitative data is called mixed methods. In summary, the choice of study design depends on the question being asked, time and resources available. Each study type has its strengths and weaknesses. The RCT is the best study design for testing interventions as it eliminates many types of bias. With the prospective cohort design, individuals are disease-free at the start and are followed up until the disease develops. The case control design is the quickest to carry out, but subject to the most bias. Qualitative studies provide an insight into locally held views and opinions that influence behaviour.